Welcome, everyone. This is Lisa Dulski-Watkins with the Milbank Memorial Fund Multi-State Collaborative. We're about to start our special informational webinar. We're going to be hearing about some of the recently announced innovations coming from the Centers for Medicare and Medicaid Services Innovation Center. Specifically, we're going to be hearing about Primary Care First, which is what is now in place or will be in place, rolled out as what we have been anticipating as the next phase of the Comprehensive Primary Care Plus program. Very excited to have our colleagues from CMS on the phone with us, and I will briefly introduce them. As a quick housekeeping reminder, please mute your audio if you're not speaking. There'll be plenty of time for question and answers after the brief presentation our CPC Plus colleagues will be giving. You can also use the chat function if you'd like to make sure that a question or comment gets addressed, because I'll be monitoring that and we'll make sure to get to those. So we're going to get started. It's now 1:30 and very excited to have with us today Emily Johnson, who is with the Division of Advanced Primary Care at the Innovation Center. She is the payer lead in her position for several months. We're delighted to have her work with us and welcome her to this webinar. In addition, two other members of her team, Leah Hendrick, who is doing the CPC Plus activities specifically around practice work for some time now. So she may be joining us. And Nicholas Minter, who is the director of the Division of Advanced Primary Care at the Innovation and is the director of the Plus. So with that, I'd like to hand over the voice options to our colleague, Emily Johnson.
Great, thank you so much, Lisa. I just want to make sure, can you hear me all right? It seems like there's a little bit of interference on the line.
There is a little bit of background noise. I'll monitor and see who's still not muted and mute them. And now I'm going to mute myself, so hopefully that'll help too. Thanks.
Thank you, Lisa. And again, I want to thank Lisa and Milbank for giving us this opportunity to join you today in order to talk more about primary care first. And I'm hoping to use this time to dig into some more of the details of the model and go a little bit beyond what you might have seen in some of the initial rollout and resources that we've put out. So I'm going to spend 15 to 20 minutes walking through an overview of the model, and then we're going to open up and take your questions. And we will try to answer as many of your questions as we can at this time. And then if there are things that you're wondering about that we aren't yet able to address, we'll be able to use that to inform future communication and calls with you all. So I want to be clear that we do see this just as the beginning of our communication and outreach about the model, and are planning to have many more opportunities for you to engage with CMMI staff and have a two-way dialogue about the model. So with that, let's jump in. I think most of the folks on this call are quite familiar with the Comprehensive Primary Care Plus model, or CPC Plus. So I won't spend too much time on the background of that model. But Primary Care First is intended to build on lessons learned from CPC Plus and expand the continuum of CMMI's primary care model. So whereas CPC Plus tracks 1 and 2 were focused on making upfront investments in primary care practices to help develop advanced primary care capabilities, so focusing on practices who are either beginning or in the midst of developing their care capabilities. Primary Care First is focused on practices that have already made significant investments in primary care transformation and are prepared to take on more significant financial risk in exchange for lower administrative burden and a greater potential reward opportunity. And our objective in Primary Care First, or really what we're testing, is whether an alternative payment model that offers greater flexibility, bigger potential rewards for performance, but also, along with that, some downside risk potential, whether that can lead to higher quality care for all beneficiaries, while at the same time reducing Medicare costs and preventing avoidable acute hospital utilization. So this is a little bit different than what we were, or are, I should say, testing in CPC Plus, where we want to see us providing upfront financial support so that practices can invest in new care delivery processes and capabilities, along with in-depth learning and coaching support, whether that can lead to practices improving quality and reducing costs and utilization. So the ultimate goal is the same, but the payment structure is different, the care delivery requirements are different, and the type of practice that we're focused on is a bit different as well. This model is also intended to offer payment options for practices that specialize in complex chronic patients, as well as those that want to focus on caring for seriously ill patients that are not currently having their care appropriately managed. And I'll dig into a little more of what we mean by that in just a few minutes. And then finally, I think especially important for this group is that, like CPC Plus, this is a multi-payer model. So we are looking for payers who are willing and able to align with us in the areas of payment, quality measurement, and data sharing. And I should also just add, like CPC Plus, Primary Care First is a 5-year model. This map gives an overview of the regions where we'll be offering Primary Care First in 2020. You can see it's the 18 current CPC Plus regions, in addition to 8 new regions, which I'll just rattle off real quick. That's Alaska, California, Delaware, Florida, Massachusetts, Maine, New Hampshire, and Virginia. And we've been getting a number of questions about how we chose these regions, so just to address that up front, we were looking for regions, A, where we had reason to believe that there would be significant interest in participation, and then B, where offering the model wouldn't interfere with the evaluation that we already had underway of CPC Plus. So we use practices in many of the states where CPC Plus isn't offered as a sort of control group for that evaluation. So if you start including your control group in a new experiment, suddenly you've messed up your ability to test the effect of your original experiment, which in this case is CPC Plus. So that was a big consideration for us when we were selecting these regions. Now, within the Primary Care First model, there are going to be 3 payment model options. And the options vary based on whether practices are choosing to accept assignment for a group of patients that we're calling the seriously ill population, or SIP. And the SIP patients are patients who are showing signs of serious, unmanaged illness, and who lack either a primary care practitioner and or effective care coordination, which is something we're going to look at by looking for a fragmented care pattern with visits to a variety of different providers. Practices will have the option to accept assignment of these patients from CMS, and then they'll be responsible for engaging these patients, coordinating their care, and hopefully helping to stabilize them clinically. So option 1 is actually for practices that choose not to accept SIP patients, but are joining the model with a focus on their current patient population. Then option 2 is for practices who choose to care only for SIP patients. So we imagine these will be fairly specialized practices with advanced capabilities focused on complex patient populations. And then option 3 is for practices who want to participate in both options 1 and 2. So participating with their current patient panel and accepting assignment for SIP patients. As I mentioned, we're expecting that practices who participate in Primary Care First are going to already have made investments in advanced primary care capabilities. So in contrast to CPC Plus, we're going to be less prescriptive about the capabilities that practices must develop, and also require significantly less reporting around care delivery capabilities. So again, the idea here is that we're trying to increase flexibility and decrease burden in exchange for practices being willing to accept greater risk. This slide lists the care delivery functions that we'll be expecting Primary Care First practices to meet. So that's providing 24/7 access to a care team practitioner that can access the patient's medical record in real time. It's using a care management strategy that risk stratifies patients and targets resources accordingly. Integrating behavioral health care and assessing and addressing patients' psychosocial needs. Creating an advisory process for patients and their caregivers to give feedback on opportunities for practice improvement. And setting goals and seeking continual improvement related to patient and caregiver engagement. Now, the Primary Care First payment model is structured with several goals in mind. So first and foremost, we're striving to promote patient access to advanced primary care, both in and outside of the office, especially for complex chronic populations. We're also seeking to transition primary care from fee-for-service payments to value-driven and population-based payments. And third, we want to be rewarding high-quality, patient-focused care that reduces avoidable hospitalization. So here's how the payment model is going to work. First, there's what we're calling the total primary care payment, or TPC piece. And this payment is a hybrid blend of a professional population-based payment, which is calculated on a per beneficiary per month basis, as well as a flat primary care visit fee that's paid per face-to-face visit. So the per penny per month population-based payment is a move away from the fee-for-service model, and it's intended to give practices flexibility to deliver care in innovative and patient-centered ways that don't necessarily rely on an in-person visit. And then the flat visit fee is intended to balance out the incentive that you might create with a population-based payment to deliver less care. So we're ensuring that practices still receive payment when patients need to come into the office for face-to-face care. But that flat visit fee is also intended to be simple and reduce burden for practices, since it's reducing the time or the need for that kind of time-consuming, resource-intensive documentation and coding activities. So overall, we think this strikes a nice balance between some of the potential unintended incentives of both fee-for-service and population-based payment models. And together, for practices with average risk patient populations, this total primary care payment with both the population-based payment and the flat visit fee is calculated to be about equivalent to historical fee-for-service primary care revenue. And I'll talk in just a minute about how this is adjusted for practices with higher risk patient populations. The second aspect of the PCF payment model is the performance-based adjustment, or PBA. And the PBA can be positive or negative. So practices have the opportunity to earn up to 50% of their total primary care payment through the PBA, or lose as much as 10%. And the PBA will be calculated based on a practice's performance on a quality gateway, which we'll talk more about in a minute, and then based primarily on its performance on a measure of acute hospital utilization. And I won't get too into the weeds of how we calculate this adjustment, although I'm happy to take questions on it later. But it's essentially a three-step assessment process where we are first comparing practices to a national reference group that includes non-PCF practices. We're then comparing them to their peer PCF practices, and finally comparing them to their own historical performance. There's going to be 5 levels of population-based payments, depending on the risk profile of the practice's patient population. So we'll be calculating the average HCC score for a practice's attributed beneficiaries, and then using that average to place a practice in one of these 5 groups, with group 1 being the lowest risk and group 5 being the highest risk. And practices will receive the same population-based payment for all of their patients. So another way to say that is we are doing risk adjustment at the practice level rather than at the individual beneficiary level. And a practice's payment amount will be based on the overall risk profile of its patient panel. Now, the flat primary care visit fee will not be risk adjusted, although we do expect that practices in higher risk groups will have more face-to-face visits, and therefore will be billing it more frequently. And the base rate for the flat visit fee is going to be $50, and we'll be geographically adjusting that amount. And again, we think the benefit of this flat visit fee approach is that it's a simple, predictable payment that lets practices spend less time on claims processing and spend more time with their patients. So let's talk about the performance-based adjustment just a little bit more. So starting in year 2, the PBA will be based on a quality gateway. So this is a set of minimum performance benchmarks on a series of clinical quality and patient experience measures. Practices will need to exceed all of these performance benchmarks in order to clear the quality gateway. And if they fail to exceed the quality gateway, they're automatically going to receive a negative 10% adjustment, which is the lowest possible PBA amount. If they do exceed the quality gateway, they'll then be assessed on their performance on a measure of acute hospital utilization and have the potential to earn a positive PBA. And we chose acute hospital utilization as the key performance measure here because we think that it's a clear and actionable outcomes-based measure for primary care practitioners to focus their efforts around. And we also see that it has a strong correlation with total cost of care. This slide lists the rest of the measures that we'll be using to make up the quality gateway. So we'll be using a version of CAPS to assess patient experience, and 3 ECQMs, which are diabetes, hemoglobin A1C, poor control, controlling high blood pressure, and colorectal cancer screening. So for those of you who are familiar with CPC Plus, those measures should look familiar. And we'll also be using an advanced care plan registry measure. So those are the payment and quality components. I also want to talk a little bit about data sharing because we believe that's an important aspect of the model. And our goal is to provide timely and actionable data to practices that lets them understand how they're performing relative to their peers, and also helps them to identify specific areas where they can focus their efforts to actually drive care improvement. So practices will be able to request several different types of data depending on their level of sophistication and their data analytics capabilities. So at a more basic level, we'll be providing quarterly reports on practice utilization performance. And for more sophisticated practices, we'll be offering the option to receive claims line fees. So who can participate? This slide lists our eligibility criteria for practices that participate in the primary care first model option. So that's as opposed to the SIP or the high need model option. And we'll be looking for primary care practices whose primary care billing accounts for at least 70% of their collective revenue. And they must provide services to a minimum of 125 attributed Medicare beneficiaries. They should demonstrate experience with value-based payment arrangements, and they should meet 2015 cert. They will also be expected to attest to that limited set of advanced primary care delivery capabilities that I touched on just a little bit earlier. And our requirements for practices that receive SIP patients are similar with just a few key differences. So one, for practices that accept only SIP patients, they won't need to meet that 125 beneficiary minimum. And two, we're expecting that SIP-only practices should have a relationship with a network of providers in their community to be sure that they can meet patients' longer-term care needs. Now, I'd like to spend just a little bit of time talking about our expectations for payer partners. So similar to CPC Plus, we're going to be looking for payers that can align with our payment methodology, our quality measurement strategy, and our data sharing approach. Now, that being said, we recognize that many payers have developed their own primary care transformation programs, which may vary by region to region, and which may take different approaches to incentivizing and rewarding higher quality care. And many payers have many years of experience with developing and refining these primary care-based programs. And also, in many cases, may be dealing with different populations than Medicare. So commercial populations, Medicaid populations that have different care needs. So we want to ensure that we're recognizing these regional contexts and recognizing the many years of experience that our payer partners have with these models, and ensure that we aren't dictating kind of a one-size-fits-all approach. So we want to allow for flexibility and regional variation, while also ensuring that all of our aligned payers are working and encouraging practices to work towards the same objective. So for example, even if our payment models aren't perfectly identical, we want to be sure that they are kind of subverting that fee-for-service incentive to bill for volume and creating an incentive to improve quality of care and patient experience of care while reducing utilization and cost. So that's kind of the higher level payment principle that we want to be aligning on. And on quality, we recognize that the exact same measures might not make sense for all of our payer partners' populations. But at a minimum, when it does make sense, we'd like to be using the same measures and even if possible, the same measure specs so that we're reducing reporting burden for practices and allowing them to assess how they're doing across their entire patient population. And then on data sharing, of course, the gold standard here is data aggregation, where practices are seeing data on all of their patients in the same data platform across different sites of service. But we also do see value in a variety of different data sharing efforts. So aligning on reporting timelines, aligning types of data and level of data shared, and those are principles that we'd like to promote as well. So I think the bottom line here is that we're really thinking about this from the perspective of what is the objective of alignment. And it's offering practices consistent incentives, it's reducing practice burden, and it's allowing practices to treat all of their patients the same, regardless of what insurance card they carry. So we'll be assessing payer proposals on how well they're contributing to those kind of high-level objectives. All right, so finally, how do you apply to participate? And this just gives an overview of our timeline. We're going to be doing a staggered application process with practices applying in spring 2019, followed by payers in summer 2019. Now, we are going to allow payers to submit a non-binding statement of interest form during the practice application period. And payers that submit this form will be able to find out how many practices applied in the regions where they're interested in participating. So our hope is that this allows payers to make a thoughtful, informed decision about where it makes the most sense for them to participate in the model. And at the same time, we're also hopeful that payers who are interested in participating will use this opportunity to encourage practices in their regions to apply during the practice application period. And we'll then be making practice and payer selections in fall to winter 2019, and are planning to launch the model in January 2020. And then the first round of payment changes will go into effect in April 2020. So that is, at a high level, the information that we were hoping to share today. At this point, happy to open it up to questions, and I would also just love to hear reactions, comments, feedback to what we're proposing. So Lisa, I don't know if you want to kind of take the lead on facilitating Q&A?
I'm happy to do that. One thing I do want to just mention is that a couple people have been using the chat, so I'm going to be reading those questions, but I've just unmuted everyone. If you have noise around you, please mute yourself if you're not talking, but I unmuted all the lines so that people can ask questions. So actually, I'm going to ask a question first, Emily, if I may, just on the timeline that you just showed us. So this talks about practice applications starting in spring of 2019, which is now. And is this, I guess we just need to clarify if that's practices in the current CPC Plus regions, if that's practices in the new regions that were designated last week, and sort of what the implications are that for.
Yeah, that's a good question. So when the practice application period opens, the application will be open to both new practices in current CPC Plus regions, so practices that are currently not participating in CPC Plus, and it will be open to all practices in the so to put that another way, we are not allowing current CPC Plus practices to participate in the first performance year, which begins January 2020. That being said, we think that there will be opportunities in the future for current CPC Plus practices to participate.
Thank you. So I'm just going to read a couple of the questions that came in. There are several from our colleague, last name is Picone. And the specific question was how many patients a practice can receive that will be classified as sick, if there's a limit to the number of patients that they can serve.
Sorry, Lisa, I just want to make sure I heard that right, because we're again getting just a little bit of feedback. So the question is there a maximum number of sick patients that a sick practice can receive or would be assigned?
Exactly.
Is that right?
That is the question. That's right.
So this is Nicholas Minter, and that's a great question. Just to give again, to sort of reiterate a little bit of the detail here. I mean, for this particular population, we plan to identify using sort of claims and health attributes, as well as sort of looking at primary care coordination or other care coordination to identify individuals that would fit this definition. And then we would sort of assign those to practices that are willing to receive them, after which time I think, clearly it will be up to the beneficiary and the practice to form that relationship. Currently, we have not set a sort of maximum amount. I mean, we are still finalizing the policies around how that will work. We do want to be very sensitive to practices' varying capacities and capability to handle large patient loads, but we do not have a hard and fast maximum at the moment.
Thank you, Nick. So there's a question that's more general one from Adam Whitlock. Is there a limit to the number of payers that will be selected for each of the designated regions? Or is there a corollary, an ideal number of payers that you'd like to see in a region?
Yeah, that's a great question. So we have no limit on the number of payers that we'd be selecting in a given region. Any payer that responds to the solicitation and has a proposal that aligns with our approach would be invited to participate in the model.
Great.
Yes, this is Bhavesh Rajani from YAML CCO. I had a question. You mentioned about risk stratification and indicating the different levels of payment or a Medicaid plan, managed care Medicaid plan. So how does that, is there a standard method you're suggesting for other insurances to use in terms of risk stratification that would be, held for everyone to follow about how to do that?
Yeah, it's a good question. So this is what we're going to be doing is calculating an average score for a practice's patient population and using that to tier them into one of these 5 risk groups that determines their population-based payment. So this is what we're doing in our kind of Medicare approach to this. So not necessarily speaking for Medicaid or a Medicaid managed care, what we're doing in Medicare. And I think this is kind of the level of specificity where we would not necessarily require that a payer partner was matching what we were doing exactly. I think, if it is possible to be consistent, we will be sharing details about our methodology and where we are setting the cut points for tiering. So if you are able to use that as a model and build your program around that, I think we would see that as a great thing. But this is kind of a higher level of detail or specificity than we would be requiring from our payer partners.
Okay, great. Here's another question of payer participation. So there's a question of whether Medicaid managed health plans can apply on their own behalf or if they will be required, as they have been previously, to apply through the state. So for some states, for example, in Michigan, it'd be helpful, it would be easier to manage if the Medicaid really apply on their own. I'm going
Sorry, Lisa, I'm gonna try and repeat that back to you.
Okay, sorry, I'm trying to find the person who's, here we go. I've got her. Okay, go ahead.
Great, so the question is whether a Medicaid managed care plan would be able to apply on their own or whether they would need to apply through their state agency, is that right?
That is correct.
Great. So I think for those who are familiar with CPC Plus, I don't think it will work any differently than that, but I think it is, so we are open to having Medicaid managed care plans apply directly, but I think it will be important for plans to check in with their state agencies and confirm how the agencies would like to have them participate.
Thank you, Emily. So we have a couple of questions around the current CPC Plus folks, and one of the questions is if a CPC Plus currently participating CPC Plus practice does not join or is not accepted in 2021, will there be other opportunities for primary care practices once CPC Plus is sunsetted as planned in the total of 5 years? And a question, I realize no one can predict the future exactly, but what is the talk in terms of CPC continuing beyond 2021?
Yeah, no, that's a great question. We understand that there are, especially as there are new opportunities, folks are sort of looking to the future. So what we are talking about today, our current plans are for CPC Plus to continue for its 5-year performance period. As I think we're talking about here, there is a primary care first model that is beginning next year. In terms of what the future holds, we don't have any other announcements at this time. I think that we do continue to acknowledge and recognize internally that there is a lot of work that has been done across CPC Classic, as we now refer to it, and CPC Plus, and we clearly want that work to continue. One of the reasons that we are so fastidiously guarding the evaluation of the current CPC Plus model as we are looking toward other primary care opportunities. And so as we look to the future, I think we will be looking toward that evaluation, but also thinking through additional opportunities for primary care to move away from fee-for-service and build these capabilities, I should say, that we think will drive improvement in healthcare all the way across the spectrum.
Thank you, Nick. So I have a question that came up about the SIP option, and the question is really what type of algorithm is going to be used and criteria for selecting those patients, and is that going to be available for the and then are there any opportunities for beneficiary incentive partner with their assigned patients?
Yeah, so it sounds like the first part of that question was what criteria we're going to be using to identify SIP patients. And the second part was whether there would be any sort of beneficiary incentive for beneficiaries to participate in the SIP component. So I'll start with the first question and then maybe look to some of my teammates on the second question. So in terms of criteria, we are first looking for patients with what we're calling a fragmented care pattern. And the way we're defining that is they don't have a majority of their E&M visits in the past year with any one provider. So that they're receiving E&M visits from a whole range of providers rather than appearing to have one specific primary care practitioner who is leading and managing their care. So that is the first criteria. And then the second set of criteria, and these three that I'm going to run through are kind of an or criteria. So if they meet the first or the second or the third of what I'm about to run through, they will be identified through our algorithm. So first is a certain HCC level cutoff. That's something that I think we'll be able to provide more information about in the future about what that specific cutoff will be, but it will be based on HCC risk score. The second criteria will be looking for measures of frailty based on durable medical equipment usage. So for example, use of a hospital bed. That is the second. And I'm looking at Nick. I am blanking now on the third.
Yeah, no, that's really helpful, Emily. I mean, the third sort of criteria, if you will, like so unplanned, sort of fragmented care pattern, and then one of the three. The third of those options is 2 or more unplanned hospital visits within the last year. And so the idea, as Emily was articulating, is that we want to identify those individuals that do sort of have these indications that they are seriously ill and could benefit from better care management, and also confirm, of course, through our claims data that they are not already being managed by one central provider, be that primary care or in some cases specialty. We are, just to clarify, we're not only looking at PCP in there.
Lisa, would you mind repeating the second question?
Sorry, I was muting myself. Sorry. Yes, I'll go to the question. So the question was then, are there opportunities for beneficiary incentives for them to partner with their providers in this program?
Yeah, so I think internally we were, so I think that we're kind of internally sort of trying to understand exactly what the questioner is sort of curious about. What I think we can share is that, broadly speaking, we are interested in making sure that we are removing barriers for beneficiaries to receive care, and talking internally with our colleagues, both within CMS, but also continuing conversations with our colleagues in the Office of the Inspector General at the larger Department of Health and Human Services to figure out if there are certain amenities or restrictions that we can remove that would allow providers to better facilitate the provision of care for this population, which is especially maybe high need or frail, but also the general population in the model.
Great. And I actually, the questioner is on the line. I know, Diane, I think, were you thinking, this is from Diane Marriott in Michigan. I got the impression
especially for the seriously ill population, or the seriously ill population, kind of they've, you know, they are attributes of a very special set of patients who may have had obstacles or have much going on, and one of those things we would anticipate maybe financial, or in terms of anything that could be done that could make it easier to provide that linkage and opportunity to partner between the practice and the patient in need. But Nick, you're right on target. You guessed accurately. We knew that would require some coordination with some other agencies there, and we're wondering if you were exploring it. We think it's great that you are exploring it and trying to make something come to be.
Great, thank you. So I'd like to just move on to a slightly different topic. We had a question, and as you mentioned, Emily, that these are practices that really are already advanced in a lot of their activities and efforts. But a very prominent part of the previous CPC Classic, CPC Plus, and even the, well, I guess those two programs specifically have been learning and practice transformation support through federal contracts and then regional dispersal of those resources. So a question is, what kind of opportunities will there be for learning activities for practices, recognizing that they will be at a smaller scale?
Yeah, great question. So we will be continuing our national learning community for these practices. So they'll have access to national webinars, national calls, reports, and deliverables. We'll have access to all of those materials within sort of at the national level. What we won't be doing for primary care first practices that you do see in CPC Plus and in Classic is some of those more regional-based learning sessions and learning activities. I think we are absolutely open to practices themselves continuing those activities and working with payer partners on those activities. But again, recognizing or expecting that these practices are already quite advanced in their capabilities, we'll be doing less of a focus on the regional learning collaborative.
Thanks, Emily. Are there other questions from the group? I can continue reading from the chat questions, but anyone else want to speak up and ask a question right now?
I have a little more specific question, Lisa. It's Peter Beccini from Aetna.
Sure.
And whoever can answer. And I know today's look for CPC Plus has the, presumably 5 categories that may closely resemble what you guys are going to assign to practices in terms of their relative risk scores. So do you anticipate it being close to that, and or will it adjust on a quarterly basis, or do you anticipate that in place for a year or maybe semi-annual? You may not have that, but just a question.
I'm sorry, I just want to make sure we understand the question. Is it about how often we're going to be calculating that risk score average and assigning practices to tiers?
Yeah, that is one part of it.
Yeah, so we're going to be doing that on an annual basis. And then I apologize if there was a second part to your question. I think I missed it. If you wouldn't mind repeating it.
No, not a problem. Would it be similar to what we're seeing today in CPC Plus with the top decile and then the quartiles?
I think what you're asking about is the way that we stratify patients in track 2. So the payment methodology in primary care first is very different than the track 2 payment methodology, in so much as in track 2 we pay a different amount per beneficiary to the practice. In primary care first, we are looking at a practice's overall population and assigning the practice a risk score based on the average HCC score of their total practice population. And so then the payment is the same for each beneficiary in the practice because it's based on the average risk score of the whole population. Does that answer your question?
It does, but I was trying to approach getting closer to how will you sort of assign those 5 levels of risk for the annual payment? I thought I remember hearing that there'll be 5 levels of payment. Not individual, obviously, to the patients, but...
You're asking what the groupings are for the practice.
Right.
So, I could pull it up, or
I'm sorry, this is Lisa. I'm just going to interrupt for a moment. There's a fair amount of background noise. If folks are, please just mute yourself if you are not speaking. Thank you.
So there is a table that goes through the HCC score associated with the different groups that a practice can fall into. We left it out of this presentation sort of for simplicity and time. We wanted to be spend more time answering your questions, but that slide will be available on the Primary Care First website in the very near future. It's something that we do on our live webinars, so unfortunately I'm not going to be able to answer it here and now, but that information is available and accessible to you on the Primary Care First website, and also once we release the RFA, it will be in there. So certainly not trying to hide the ball. We just wanted to get to your question. So apologize that level of detail was out.
No, that's okay, Leah. Thank you very much. So just actually as a specific aside question, there have been a couple of requests for access to this presentation. It sounds like this is probably going to be on the website relatively soon. Is that correct?
Yes, so that is our plan, is to post recordings of the webinars that we've been having on our website in the very near future.
Excellent. And I would like to also just announce to this group that's on the line today, we are recording this webinar. It will be up on our website probably later today or tomorrow morning, and anybody can have access to that as well. And we'll send out an announcement about that when it's up. So I'm going to...
the Health Collaborative, I was wondering if I can segue from the question about the practice risk groups just for a moment.
Yeah, go ahead.
So this was a question that I had in chat, so you can go ahead and check it off your chat, but I thought that it would feed well from the practice risk group. Will the practices have access or be informed of their practice risk group prior to signing their participation agreements to help them with their financial analysis?
Hi there, is this?
So sorry, we were actually, it's a good question, and we were looking at our timeline. I will say that clearly practices will know what risk group they are assigned to. The question is sort of, will that happen before they sign their participation agreement or not? I think, you know, we are going to make as much information available to practices as we can. I think we are needing to just we are sort of finalizing that policy in particular. I think from our standpoint, you know, we have, I think we understand that practice will want to know this information. We also are trying to make sure that we calibrate sort of the payment levels such that, you know, they are commensurate with whatever the risk and patient profile level is. And so even if that information is not available when a practice is signing the PA, you know, we are certain that sort of we are providing enough, we will continue to provide enough information, I should say, in the ongoing future so that practices can make educated decisions about whether or not this level of risk and this sort of model is right for them.
Thank you, Nick.
This is Bhavesh Rajani again. So I'm just interested in how you're going to account for beneficiaries seeking services outside the practice. What's the methodology around that, and what's going to happen to the payment?
Yeah, that's a good question. So I can say just at a high level, we will be incorporating some kind of adjustment that does account for patients seeking care outside of the PCF practice that they are attributed to. So we are planning to do an adjustment that looks at how many visits patients are receiving outside of their attributed practice and using that in future quarters to adjust that population-based payment. But some of the details of how that adjustment is going to work specifically will be forthcoming in the payment methodology paper that we'll be putting out.
Thank you. So I'm going to read another question from the chat. So looking at the three options that were listed based on the SIP criteria that was described, it's specific to CMS for identifying eligibility. So understanding that interested payers who want to participate may have a different population and may have different claims experiences. The question for you is, are the payers expected to run their own algorithms for identifying and contracting with practices?
I'm sorry, just wanted to clarify, the question was specific to SIP patients, was that right?
Yes, that's correct.
Yep. So I think we are envisioning that for payers who would like to do some form of the SIP model in their own aligned model offerings, that they would be establishing their own criteria and methodology for identifying those patients. Of course, again, we will be publishing the details of our methodology, and payers are welcome to use that as a foundation and a basis. But we only have the data and the capability to run that information for Medicare fee-for-service beneficiaries.
Any other questions from the crowd before I launch into more of the chat questions? Okay, well, here's a question. If the current CPC Plus market does not have enough practices to apply for year one, would they be allowed to apply for another year when they would still be eligible? So I'm not quite sure, the timing of this question is a little bit confusing to me. And Alicia, if you're still on the line, it would be great if you clarified that. I guess.
Yeah. I apologize, Lisa. I'm not sure that we followed the question.
I think this is one of the problems with the chat. Sometimes the typing is a little.
Can you hear me now?
We can hear you. Yeah. Hi, Alicia.
Sorry, I wasn't very clear probably on that question.
No, that's great.
Let's say, for instance, the Arkansas market, given our 182 practices that we have today, and those CPC practices are advanced practices that cannot apply year one. So we would not have enough practices maybe for our initial application. Would we as payers and as a market and practices be eligible to apply for year two and I may still not be making sense, but I just fear that outside of our CPC practices, maybe we don't have enough of advanced practices for year 1 to qualify. So then in that case, can we apply in year 2?
Yeah, I think we definitely hear that concern, and I think we are planning to open for the second performance year to new payers as well.
Thank you.
New payers and new practices? That is, with that.
Yeah, I think at this time that's probably not something that we could comment on.
All right, got it. All right, that's one of the many things that will be determined later. That's fine. Other questions or comments?
So, sorry, Lisa, just, I mean, I think in reflecting on that question a little more, I do think, you know, just to clarify, in the first year, in a region like Arkansas, to use the example, you know, it is open to sort of practices non-CPC plus. In the second performance year, and it's open to payers. In the second performance year, we foresee opening it to payers as well as CPC plus practices that wish to transition into primary care first. At this time, I don't think that we have an expectation that we would allow non-CPC plus practices in an existing region such as Arkansas to apply at that time. So, you know, so non-CPC plus first performance period, CPC plus practices that wish to transition in the second performance period. I just want to make sure that that message is clear, because I do, you know, as you all talk to your practices, I think it's kind of an important stipulation.
Thank you, Nick. I'm going to move to a couple questions that came into the chat. One is a question about whether the care management codes that are part of the fee-for-service would also be flat rate, and will there be a list of codes so that the practices and payers know which types of visits are considered flat rate versus others that will still remain in the fee-for-service structure?
So I'll just start and take a first stab at that. The codes that will be eligible for the flat visit fee, will definitely be publishing that and making that available to practices well in advance of the start of the performance period. And if you are familiar with the CPC plus fee alternative to service payment, I think it's a similar set of codes that are involved in that payment.
Thank you. So another question came in around the SIP, S-I-P. The question is if there's a formula or algorithm that a practice can run on their own to see if they are currently managing any patients that would qualify for them. And what those
I'm really sorry, Lisa. I think we're going to have to wait for that background noise to stop because we just can't
yeah,
hear
I'm
you.
sorry. I'm trying hard to mute people as I hear them. I got them. I got this one now too. Okay. Catching insects. Okay, so is there a formula or an algorithm that a practice can run on their own to see if they're currently managing any SIP patients? And what the requirements for a patient to be categorized, if there are additional requirements such as, besides the no primary care provider, high risk and high utilization of inpatient services?
So, yeah, so this is Nick again. I mean, I think that's a great question. I think we, you know, part of the reason that we are doing the identification of these patients is we believe that they are not being managed by a practice currently. And so I think, you know, it's hard to speak to every individual situation clearly, but if a practice is working and coordinating care for that patient, I think that it is likely that they would not qualify as a SIP patient. Simply because their care is being coordinated. We don't necessarily, and I'll be honest, sort of as a policy goal here, I don't necessarily, we see this model as being one in which practices can identify their own patients to refer to the SIP, you know, for the SIP payment option. It is really targeted at patients that are not being well coordinated by any provider currently, with the aim of ensuring that they are linked up with a primary care practice that is especially situated to provide care and frankly speaking, to coordinate the sort of health improvement of that individual.
Okay, thank you. And then one more SIP question that came up as a just quick follow-up. Is the payment for the SIP only for 1 year, or does it continue beyond 12 months?
Yeah, sure. So and this is a question I think that goes to the sort of foundation of what we're trying to do with the SIP payment option. The idea is, with this payment option, is that it is intended to provide additional resources to stabilize these patients that otherwise may be bouncing around from care setting to setting, or you know, finding their care in a hospital because they otherwise don't have the resources or the relationships to fall back on. And so the intention is to, you know, to sort of provide an episodic sort of payment to stabilize their care and then to help them transition into a primary care setting, such as a primary care first practice.
This is Tiffany. If I can ask a second question to that. So then once they transition to the primary care practice and they are, their risk score is incorporated into the practice risk group, and they receive a PMPM off of that risk score for the practice. So they're just they're added in the bennies for the primary care first practice. Does that make sense?
Yeah. So I think your description, I mean, my understanding of your description is correct. Once that patient, once they leave, if you will, the seriously ill patient payment option, if you will, and move into primary care first practice, they would be integrated into that practice's attributed beneficiary list. And
okay.
Of course, that would be factored into the practice's overall score, but they would receive the same payment as every other patient in that part of the model.
Okay, thank you.
So I want to be mindful of the time and turn over to our colleagues at CMS. If you have any final comments you'd like to make at the end of this webinar, just any things for people to think about or offering up other opportunities for further information.
Yeah, Lisa, again, really appreciate you providing us with this opportunity. All of these questions have been great. It's really helpful to hear which portions of the model you have questions about. I'll make a plug for just a couple of future opportunities to engage with us. One, our team will be having another series of model webinars on May 16th. So that's something that you can register for on the Primary Care First website. And then in addition, at our national CPC Plus meeting next week, which is May 8th and 9th, we'll have several sessions on the Primary Care First model. One on our first day of the meeting, where we're having kind of a payer-focused meeting in conjunction with the broader meeting. So we'll have a session, again, focused for a payer audience. And we're hoping to kind of treat that, you know, again, we'll provide some details about the model, but also kind of hoping to treat that as a listening session or a two-way dialogue where we can hear from participants what they're thinking about the model, what kind of support they might need or wish for from CMS to help them be able to engage with the model or to help them recruit practices into the model. I think we'd also be very interested to hear payers' thoughts on alignment principles, what in their mind makes sense to ask for with respect to alignment to ensure that we have models that, again, are accomplishing the goal of actually having multi-payer participation. So aligning incentives, reducing practice burden, allowing practices to treat their patients in the same way regardless of insurance. So what's kind of sufficient and what's necessary to look for with respect to alignment to achieve those goals. So those are all things we'd love to hear more about at our national meeting session next week on May 8th, and also across future opportunities to engage. I'll also just call out on this slide that's showing here, our primary care apply at Telligent.com is a great way to submit questions to us and get additional information from the team.
Excellent. So once again, I want to give very hearty thanks to Emily Johnson, Leah Hendrick, and Nicholas Minter for sharing the information today with us, and to everyone on the line for dialing in. I've also encouraged you to take advantage of what other opportunities come up, and please feel free to contact us at Milbank. We're happy to convey information and share what we learn as well. Thanks, everybody. This is recorded. You will be able to listen to this again if you wish, or share it with your colleagues. And as we heard, there will be availability of slides and other documents on the Primary Care First website soon. Thanks, everybody.
Thank you.
Thank you.